Excellent. So thank you very much, everyone, for the invitation, first of all, and as well for sharing your lunchtime with us. I'm excited to discuss a new clinic that we established at the MUHC called the Onco-Genodermatology Clinic. I have no conflict of interest in regards to this presentation. So basically, there are three objectives to the presentation today. So first and foremost, I hope that I can present something useful to you all as clinicians in regards to the Onco-Genodermatology Clinic. The word itself may sound complicated and very narrow, but as you'll see throughout the presentation, there's probably some patients that could fit into this criteria and that you may actually find the clinic helpful to your service. The second objective is to recognize some cutaneous manifestations that can suggest an underlying oncogenodermatosis in an adult, and if you feel comfortable, maybe even initiate workup for some of these conditions. Okay, so why are we looking into oncogenodermatology? So skin is the largest organ of the body, and I know that dermatologists were very passionate about it, but of course there are some organs that are more important for survival than skin. But regardless, skin has many rare diseases. And just looking for genetics diseases that affect the skin, there is 560 distinct genetic syndromes described, and that's as of 2020. So this number is even higher now. And basically, these disorders are very broad spectrum, but can be narrowed down in some categories. For example, the disorders of cornification, such as ichthyosis and keratodermas, or disorders of barrier defect of the skin. Also, disorders of pigmentation. You may have seen some of this, by example, xeroderma pigmentosum, which is more DNA abnormality, but they can have pigmentary abnormalities, neurofibromatosis, by example. Vascularity disorders with vascular malformations or vascular tumors that are inherited, blistering diseases, which we tend to see rarely in adults, but we still have some consult for these cases. Example would be epidermolysis bullosa. And the last one is the one which is the focus of our clinic and the presentation today is the tumor formation. So what is the Onco-Genodermatology Clinic, and a little bit why did we come up with this idea? So at Onco-Genodermatology Clinic, there is not really a term that is defined for this. So this is something that we decide to define ourselves. So basically, there is a genetic disorder, a Mendelian, with a mutated usually gene or a couple of genes that will provide a higher risk of either a skin cancer, example, familial melanoma syndromes, or there will be characteristic cutaneous stigmata that may actually ease or allow an earlier diagnosis of a systemic tumor syndrome or specific tumor syndrome, and we'll go through example of this. So who are we and why did we come up with this idea? So basically, when I graduated and when I got the position at the MUHC in 2018, probably because of my interest in rare diseases in dermatology, I was getting a lot of these consults about genetics. And at some point, I was very interested actually to try to do genetic testing by myself, but I was rapidly overwhelmed. What was overwhelming was the amount of paperwork, of course, to fill, but that was not even the problem. The problem was when the genetic test comes back positive, then we need to take in charge the family and ensure family screening. And there I felt that basically I absolutely need the help and the guidance from a genetic specialist. So we got together and basically we founded this clinic, which we really started doing since October 2022 with Dr. William Fuchs, who you all know probably very, very well from Department of Genetics. Dr. Tanya Cruz Marino, also from Department of Genetics, a medical geneticist, and myself. And we even recruited our first master student, Dr. Lydia Ushen, who you see on the lower left quadrant, who's a PGY3 dermatology resident and actually pursuing a master's degree in oncogenodermatology. So what is this clinic? It's a multidisciplinary clinic, dermatology and genetics. And the goal of it is really to confirm a diagnosis of a suspected oncogenodermatology, or even more broad than that, a genodermatology syndrome, direct screening if there is a screening for systemic involvement, and also ensure counseling and screening of affected family members. So how do we function? So we are based at the Montreal General Hospital, and we're located at the dermatology clinic, the L8-210. We have a clinic full day, one Friday a month, and we think that we can see actually in important volumes. And right now, the wait time is not too bad. We can usually accommodate new consults within 3 months. We see about 30 patients per day, which is once a month on a Friday. In the morning, we do new consults, and we already had blood test slots reserved for our clinic. So we do genetic testing immediately on the first consult. And in the afternoon, we reserve the entire afternoon for result disclosure and workup should there be any workup required. We also, so we test the proband, which is the consult that you refer to us. And if the proband tests positive, we will take care of their family members. We offer genetic counseling directly to the clinic, which is primarily taken care of by Dr. Fuchs and Dr. Cruz Marino, and also through the genetic counselors from the Department of Genetics. We will coordinate screening if there is multi-system disorders, and we will also take care of the skin-directed management of some cases, and I'll show you examples of this. We also have a research component to the Onco-Genodermatology clinic, and many of the patients who tested positive for a syndrome may decide if they want to participate in the cancer predisposition biobank. So what do we see? So first of all, we see some hereditary skin cancer syndromes. What are those? It's basically skin cancers when we expect that there could be actually genetic cause for their occurrence. So the most common example we see in the clinic will be patients with a suspicion of a familial melanoma. Usually those patients will be the ones that have more than one melanoma, usually 2, 3. Sometimes we have patients that have already underwent 10 or 20 melanoma resections, and their physician, whether a dermatologist or oncologist or surgeon, will suspect a familial melanoma. So this is the common example, and we see about 20 to 30 cases per year of this. And of course, this is just 1 year anniversary of the clinic. We also see familial basal cell carcinoma syndrome called basal cell Nevo syndrome of Borland, and about 10 cases per year so far. Another syndrome that you may be surprised that I put it in this category, it's Lynch. So when you have Lynch syndrome, but it affects the skin, we call it Muir-Torre syndrome. And those patients can present with a high risk of a special type of skin cancer called sebaceous carcinoma, which often will affect the eyelids and can be quite dangerous, especially for the eye, and can also present with atypical sebaceous tumors, as well as keratoconthromas, which is a type of squamous cell carcinoma of the skin. We see about 20 to 30 cases per year of this as well. Thank you. So this is just an example from our patient of a melanoma. So this patient had 20 melanomas by the time she presented to us. So the second category of what we see is hereditary cancer syndromes. So the most common one, you will probably be surprised, it's a syndrome called hereditary leiomyoma muscle renal cell carcinoma syndrome. So far, we saw actually more than 70 cases in a year. And we'll reserve the end of my talk on this syndrome because there is something special happening in Quebec. So this is the case of Lynch syndrome. So you see this kind of yellowish papules. So yellowish are characteristic of sebaceous gland or the oil gland of the skin. So this is a patient with Lynch syndrome, which has cutaneous manifestation. We call it Muir-Torre. And also we see quite a bit of Cowden syndrome, which is in the P10 hamartoma spectrum. But we're not limited only to the oncogenodermatology because right now there is no adult genodermatology clinic. So we accept so far, we're able to accommodate pretty much any other genetic dermatology inference syndromes. And the example that was on previous slide went on a bit fast was leopard syndrome, which is on the same spectrum on Noonan. So we'll start with the first, and that will probably ease you in the presentation of something that you've heard about and you probably even saw in your clinic potentially. So first of all, we'll start with a case. So this is a real case of our clinic. So 84-year-old Caucasian male that had a history of renal cell carcinoma removed in 2006. So normally, is it that rare to have a melanoma in 84-year-old Caucasian male? It's not. However, he had a renal cell carcinoma and his son also had a renal cell carcinoma removed last year. And renal cell carcinoma are a bit less common than melanoma, so that's already something that made us suspicious. But the most important thing is that he was actually my patient from my community dermatology clinic, and I've personally diagnosed 5 biopsy-proven melanomas in the last 3 years. So I referred him to our own clinic for future workup. So you have referred this patient to the Onco-Genodermatology clinic to rule out familial melanoma syndrome. Do you have any idea of what mutation may you expect to find? So this is, of course, a hard question, and even probably the R5 dermatology residents may find this question quite difficult because the landscape of familial melanoma is advancing very quickly. And there are some mutations that are very common or relatively more common, and some other ones are a little bit more specific. So in this case, the renal cancer syndrome may be the hint. So in this case, we suspected MITF mutation, and we have confirmed it with genetic testing. So melanoma and genetics. You're probably wondering, how often should we suspect it? So it's actually quite rare, and when the patient asks me, is this melanoma genetic, the answer I usually provide is that less than 5% of all melanomas have probably genetic predisposition, but overall, the familial context or the entire package that comes with genetic or skin phenotype, the color of the skin, the color of the eyes, the color of the hair, may account for actually about 60% of the risk of melanoma. So what do I mean by this? So this picture that I chose to show you, it's actually not random. So you're seeing a family. So this family is fair skin. So we see the woman, the mother is blonde. So just having fair skin and blonde hair and light eyes is already the highest risk factor for acquiring melanoma. And you also see what their family is doing. They're enjoying life. We're happy for them to enjoy life. They're able to travel great, but they're all soaking in the sun. And we know that the highest risk factor for melanoma as well is intermittent, intense sun exposure, and especially during the youth, the children who are playing in water without sun protective clothing. They possibly have put sunscreen, but sunscreen is just not enough. So this is why we may see quite a bit of familial history of melanoma, but familial history alone does not mean that they have a gene mutated that will predispose them to melanoma. So in general, in our patients who have melanoma, about 10% will report a family history of melanoma. But as I just mentioned to you, it's more complex. So most of the time, it's really due to familial heavy sun exposure and their natural skin phenotype. So pale skin, blonde or red hair, and pale eyes. But of course, less than 5% may actually harbor a predisposing mutation. The most common mutation is called CDKN2A, which accounts for 20 to 60% of all familial melanomas. So familial atypical mole and melanoma syndrome, this is the most common genetic mutation that we see in the CDKN2A gene. How do this patient present? The patient usually present with either multiple moles, they can be covered with moles on their body, or more of this funny looking moles, and that's why we use the term atypical. So you may have referred the patient to us and we said atypical mole syndrome. An atypical mole syndrome does not mean they have this genetic syndrome. For this, we actually need to do genetic testing to confirm it. So typically, when do we suspect this? So in a country like ours, Canada, where actually melanoma incidence and prevalence is common and on the rise, we have a rule of 3. What does it mean? It means that either the patient or the first or second degree family member have 3 melanomas, primary melanomas, or 3 melanoma-related cancer, which are common in this syndrome, which is primarily pancreatic cancer. In low incidence area, by example, Africa, we usually, the rule is of 2. So if the patient has 1 melanoma plus pancreatic cancer, we'll be very concerned. Or if we see a patient that has melanoma and a family history of melanoma, but it's a low incidence area where we just don't expect to see this, we'll be already cautious and we'll consider testing for these patients. So usually we will do a pedigree in the clinic for the proband, and then we will offer a melanoma panel testing, so not reserved for just one gene, but we'll do for about 30 genes they're most commonly seen in melanoma. And then if we find a genetic mutation, we'll offer a lifelong follow-up, either by us or by another dermatologist. So this is an example of a patient that was seen in our clinic with familial atypical mole and melanoma syndrome. So it's, basically what I highlighted here with the surgical marker is this atypical mole presentation. So this mole is a little bit irregular if you divide it in four. So we see that the top looks paler than the bottom, which darker. And this woman in her 60s had multiple of these lesions, and she already had 10 melanomas by the time she presented. And her daughter had 20 melanomas. That's one of the previous slides I showed you. Okay, so this is one of the melanomas that this patient developed, which was a T4, so very deep melanoma, a nodular component arising in a superficial spreading one. I'm showing you this picture of a dark-skinned individual for two reasons. First of all, it's important to remember that dark-skinned individuals also can have melanoma. It's rare, fortunately, but it can occur. It can occur as well in this atypical location, which is acral skin. And because we don't really expect to see melanoma in darker skinned individual, a family history of melanoma, so this rule of two in this patient will be highly suspicious for genetic inheritance. So CDKN2A, as you can see here, in the schematic representation of familial melanoma is, of course, the most common, but it's not the only gene. So there's also CDK4, BAP1, and TERT. What are these? So, of course, they're all primarily tumor suppressor genes. So having one autosomal dominant inherited mutation in the tumor suppressor will predispose with sun exposure and other factors to a second hit mutation and development of melanoma. And BAP1 is something that is about 10% of all inherited melanoma cases, but we actually didn't have a single one in our clinic in a year so far. TERT is telomerase complex, so that basically will cause premature aging of the DNA and predisposition to mutation. So those are considered to be high risk loci for familial melanoma. There's also some moderate risk as well for familial melanoma, and this is MITF, like the patient with renal cell carcinoma, and also MC1R. So MC1R is actually very common. This genetic mutation underlies the beautiful red hair phenotype that we see in patients that we commonly see in our clinic. And having MC1R or red hair phenotype will predispose to melanoma 2 to 3-folds. So while we saw the more pure melanoma syndrome or something that is typically associated with melanoma risk, many of the patients you see in your clinic may also need to be seen by a dermatologist. By example, the BRCA mutations. So patients who have hereditary breast cancer syndrome with either BRCA1 or BRCA2 are at high risk of melanoma, and the risk is approximately 2 to 3-fold. Li-Fraumeni syndrome, which is TP53 mutation or the major tumor suppressor gene, is at risk of any cancer, including skin and notably melanoma. So we often will offer at least a once-a-year follow-up for these patients and potentially more commonly. PTEN, another tumor suppressor gene, is underlying Cowden syndrome that you all may have seen at least once or may see once in a while. And this predisposes to melanoma up to 2 to 5-fold, depending on the study. Retinoblastoma gene and POT1. So POT1 is a more recently described, about 100 cases described so far. And this one typically will underlie chronic lymphocytic leukemia and a high risk of melanoma. I had a question from Laura. Laura, you're asking a hard question. You probably know this more than I do. Do you ever do telomere length measurement and parallel with germline testing, giving associated gene like POT1 and TERT? To be fully transparent with you, we have suspected POT1 and TERT, and it was not part of the blueprint panel. So we often, when the patient tested negative on the melanoma and we still suspected highly a melanoma inherited syndrome in some of our patients, we will then usually increase the panel by looking at telomerase genes. And so far, we have not identified anyone. So usually what we do with these cases, example of a case that we had this year is a young man in his 40s who presented to us, referred by a dermatologist for a melanoma in his scalp. Which was protected from the sun, so a bit of an atypical location. And what was very important with his story is that his father died at 43 from a metastatic melanoma, and his brother died at 43 at metastatic melanoma. So the only other living members of his family was his niece, who's 18, and she already had a melanoma removed. So in this case, basically, the melanoma did not skip a single generation. So we really feel that there is a genetic mutation in this patient, and all our tools we had so far did not detect it. So the first panel did not, then we expanded with telomerase, we didn't find anything. So very often what we do in these cases, like in the image shown here, we can actually send the tumors, so isolate RNA from two tumors, two melanomas, can be from patient and brother, by example, or like in this young woman, she had 7 melanomas removed or 8 melanomas removed. We will sequence them and we'll see if we find the same mutation in 2 melanomas. In this case, we'll suspect that basically there's a mosaic potentially mutation, and there's additional things that we could potentially do. And very often, Dr. Folks will work together with his colleagues from Europe. And there is one colleague in Barcelona right now who's looking at sequencing and using even like intronic and additional testing. So I hope I was able to answer your question partially, Laura. As you can see on this image here, Laura probably have heard about this patient. So in this case, this young woman in her 50s presented with several melanomas. So she had, as you can see here, several scars removed. But in this case, we clearly see that there is something going on and that there's probably mosaicism. What mosaicism means, it means that part of our body has its different genetic material from the rest. So we see that there's a sharp demarcation around the vertebra, around the spine, and where the right side of her skin, from the neck down to mid-shoulder to the arm, looks to be genetically different from the rest of her skin. So what we did in this case, we actually did biopsies from non-affected and affected skin, and also from the tumor, and we sequenced them using the 60-gene panel in-house, which actually was negative. So basically, now we're wondering, could it be an atypical presentation of mosaic xeroderma pigmentosum, because we have a hint of maybe there's premature aging in this patient, and also the other suspicion that we have is actually potential telomerase that may also predispose to premature aging. So sometimes we actually don't have the answers, but I think with the future and improvement in diagnostic technique, we'll be able to better and better diagnose. So nuance. So after we reviewed everything here, so after we see all of this, basically there are not perfect guidelines. The guidelines that we have is for this familial atypical mole and melanoma syndrome, but that only accounts for about 20 to 60 inherited melanoma syndromes, and the list of the different genes is expanding. So what do we do and how we kind of decide, who to diagnose or not? So typically when there is a melanoma that is diagnosed at younger age than expected, and that's typically prior to age of 18. So melanoma in children is extremely rare. So having a child diagnosed with melanoma it's a big red flag and deserves an evaluation. Second is that there is multiple relatives with melanoma. Some of the examples that I've mentioned to you, like the young man he had melanoma, his father, his uncle, his parent, his niece. So that's really high suspicious, it's on the same lineage of the family. Okay, or the individual with multiple primary melanoma themselves. And the final thing is other cancers in the family. So by example, if the patient had melanoma and there's a history of breast and ovarian cancer, that can also be suspicious for familial cancer syndrome, not exactly familial melanoma, but familial cancer syndrome. So there's an opinion publication came out in 2021, and this is actually the best we have so far. It came with like a score system to who should we test or not. But briefly what it says is everything that I just mentioned. So if there is multiple melanomas in the family or the same patient, or if there's just one or two melanomas, but there's some other cancers that are really running on the family or in the individual, especially on the same side of the family, that can be suspicious and deserves a potential referral. A question from Dr. Cormier. Should patient with confirmed short telomere, familial interstitial lung disease without any detected melanoma third mutation be followed by dermatology to screen incidence melanoma? Outstanding question to which I actually have no answer right now, because I don't think I have ever seen a melanoma case in a patient with interstitial lung disease. So I think we're kind of lacking data. So that's something very, very important. So you're welcome to refer a patient to us. Sometime when we refer a patient and something that we have never seen so far, we usually will really like do a literature review to see if there is something that we're missing. But to my knowledge, this is not something that is currently recommended, and I've never had a case so far of interstitial lung disease with short telomere that presented with melanoma, but it sounds very plausible that it could be at increased risk. And thank you, Laura, for answering the question, confirming my thoughts. The melanoma risk is only associated with long telomeres, not short. So case number 2, so this is a 34-year-old male who was referred to us by his dermatologist for countless basal cell carcinomas. So you can see that basically it's impossible to manage this because there's like just 20 or 40 on his scalp alone, and that's including his face because he had undergone many Mohs surgeries, which are quite mutilating because of the numbers of BCC that he had. And at this point, he was also known for some odontogenic keratocysts that were not very symptomatic, but he was followed by by the maxillary surgeon for that. Okay, so this is basal cell nevus syndrome. It's rare. Just to reassure you, basal cell carcinomas affect 1 Canadian out of 3, so it's extremely rare. But the genetic basal cell carcinoma risk is very rare. So we see so far about like 10 patients per year. It's autosomal dominant. The penetrance is super high, but the expression is variable. And this is very important because, by example, our Caucasian patient that had undergone CT scans, very often because of the cyst in their jaws, they grow BCCs like mushrooms. But on the other hand, we have patients who have the same mutation and they're of Asian descent. So far, knock on wood, we haven't seen a single BCCs on them because there are many other factors that will contribute to the risk of developing skin cancer. So about 80% of time, we can actually find the mutations with the genetic testing panel that we use right now. And the most common mutation is the patch 1, and rarely we see patch 2 or SUFI mutation. So this is a little bit of a specific pathway. We call it the sonic hedgehog or hedgehog pathway, which consists of patch, smooth end, and then there is signal transmission through end transcription of the Gli protein. So Gli protein is important for organ and tissue patterning. So mutation usually in basal cell nevus syndrome will usually translate in some dysmorphic features, and there is more 100 different phenotypic presentations that have been described, including some of our patients have Marfanoid habitus, by example. The cutaneous features. So this I really wanted to show you. This is one of my patients, possibly not the one that I showed the image before, but what you see here is you see small depression on the palms, and you see this often the same thing on the soles. So we call them acral pits or palmoplantar pits. It could be normal, which can be a racial phenotype. So in darker skin individuals, you can see palmar pits that could be localized to the linear crease. And we don't need to necessarily be alarmed for these patients because usually it's part of their natural beauty. But if it's something new and there's not, and you don't have a good explanation or there's some other features on history, usually it could be associated with other features. So in most instances, this will occur either with Gorlin syndrome, Cowden syndrome due to PTEN mutation, which underlies breast and thyroid cancer, and Daria syndrome, which is more a skin-limited disease of a genetic origin. And the external agent that can cause that is arsenic poisoning, chronic arsenic exposure. So I think patients who present with these palmoplantar pits deserve an evaluation in dermatology or oncogenodermatology clinic. So the other thing this patient had on the left is multiple BCCs, but you'll say, whoa, but the patient on the right also has multiple BCCs, and you're absolutely right. However, the major difference between those two patients is that the patient on the left started developing the BCCs in his 20s. And with the number of BCCs in the 20s is just way too much to be the average. So in this case, it's highly suspicious. Plus, he had odontogenic keratocyst, palmoplantar pits, and additional features. The gentleman on the right is a patient of mine who had 7 BCCs that you can see on his trunk. He also had about 10 additional on his thighs. So he literally came to me with 17 BCCs, but he's 64. And although we're still evaluating him in the Genoderm clinic, most of the time patients who had chronic sun exposure, very often history of tan bed use, we find nothing. And in this case, it's really just caused by sun exposure. So the diagnostic features for Gorlin syndrome are multiple. In general, if there is a genetic confirmation, bingo, the diagnosis is made. But prior to genetic confirmation, there are some things that should hint it, because just the presence of BCCs is not enough, as you've seen in the previous picture. So you need to usually have two major criteria, or one major plus two minor. So in the major criteria, you have multiple BCCs that usually start around age of 20, but in this syndrome, the development of BCC has been described as early as 2 years old, literally in toddlers. So that, of course, should raise a red flag. The palmoplantar pits are also a major diagnostic criterion for this syndrome. The jaw odontogenic keratocyst, as shown in this radiograph, lamellar calcification of crus cerebri, as you can see on this X-ray of the skull, and a family history, first-degree relative with the syndrome, which are your major features. The minor features are quite broad, so they usually manifest as all this dysmorphic features that come with the overexpression of the Gli protein, which is important for organ patterning. So you can have craniofacial abnormalities, vertebral or bone abnormalities, digital polydactyly, by example. One thing important to mention is the childhood medulloblastomas. This is particularly occurring with the SUFA mutation, and they can actually be life-threatening. So what do we do for these patients? So of course, the first thing is to do the genetic testing and confirm it. If the genetic testing show the common mutation, which is patch 1 or patch 2, typically what we do, we'll do a regular total body skin check for basal cell carcinoma. And I kept it regular because sometimes we need to do it every 3 months, but sometimes it's every 1 year at the beginning. Dental follow-up. We do baseline cardiac ultrasound, even in adults, because there is a small risk of cardiac fibromas, and ophthalmologic consult. Unless there is a SUFA mutation, which is exceedingly rare, there is no recommendation to order baseline brain MRI unless there's some worrisome symptoms. And we also offer management, which is treatment or prevention of basal cell carcinomas. So as you see here, it's a vitamin B3, so nicotinamide, which is available over the counter in natural drugstores, can actually decrease the risk of skin cancer by about 30%. So it's not perfect, but because it's safe, why not? So we use this often. We also use something called Fudex and other treatment, which is a topical chemotherapy if there's some precancers in order to prevent transformation. And sometimes we use systemic chemotherapy with a vitamin A analog, such as acitretin. But most of the time we'll reserve to a systemic treatment, like in the patients I've shown you. Perfect. So there is a sonic hedgehog inhibitor. It's called vismodegib. We used to have in Canada 2 of them, vismodegib and sonidegib, but the one that is commercially available is vismodegib. It's a systemic treatment, and as you've see on this publication from the New England Journal, a patient with Gorlin syndrome had multiple BCCs at the beginning. He was not surgical candidate because how many there were, and we do not recommend radiation therapy for this patient or ionizing radiation imaging because it actually will favor development of new skin cancer. So this patient underwent treatment with vismodegib, and you see 5 months into treatment, all the basal cells primarily melted. There's 2 issues, however. So first, when we stop the treatment, they will typically recur. So that's number 1. And number 2, even though it worked great, and the overall safety profile is not too bad, but they have 3 symptoms that are actually quite debilitating and can be treatment limiting, which is muscle cramps. And the muscle cramps can be very, very severe. I had patients who were admitted to Douglas because it was so bad that they just actually had like acute agitation and psychosis. And the other thing will be hair loss, which is can be a concern for some patients, and metallic taste in the mouth. There is some way we can minimize the symptoms, but it's a medication that is not very easy to tolerate. Okay, so now we'll move into the next category of patients that we see in our clinic, in which case they may not really be at high risk of skin cancer, but they have some specific cutaneous features that make us think about the genetic syndrome, in which case a multi-system or multidisciplinary management is required. So what's common to all these 4 presentations here is that the fact that this patient has multiple facial papules. What is a papule? It's basically a growth or a small lesion that's usually measured less than 8 millimeters in size. So actually the top right picture is the same patient that I've just shown you with Gorlin syndrome. So this facial papules are actually basal cell carcinoma. The patient on the lower right, you can also probably recognize it's a patient we saw in our clinic that has tuberous sclerosis complex. So tuberous sclerosis complex don't necessarily have systemic malignancies, but we do see them in the clinic because the skin lesions that they have can be potentially troublesome, and we can use a topical rapamycin treatment with some good results to improve the quality of life and decrease some consideration due to the lesions, such as bleeding and infection. So when we go on the top left, so this patient has trichomonas. So they're small, kind of warty appearing or molluscum-like facial papules, very often around the nose and typically in sun-exposed areas. So this patient has Cowden syndrome. And then on the lower left, we see as well a patient of mine. And in this case, you're probably wondering, what am I seeing? So what we see is especially when we use tangential light or dermoscopy in the clinic, and when we shine light on the patient, we see there's some texture to the skin. So if there's small bumps, and the small bumps look shiny a little bit. So very often when we say shiny, it kind of looks like a BCC, but they otherwise look harmless. So this patient has Burke-Hawk-Dubé syndrome, also a patient from our clinic. So multiple facial papules can be an important hint for an underlying potential syndrome. So this patient of ours, a 64-year-old female, presented with multiple papules on the head and neck, and that was actually the reason of consult. Her past medical history otherwise included breast cancer and colectomy for colon cancer, and one of her 5 children actually died, unfortunately, of metastatic colon cancer at age 34. And even though probably for you it's very obvious that there is something genetically going on, she was diagnosed with a genetic syndrome at age of 64 and not before that. So what is special about this papule? So they kind of look orangey or yellowish in appearance, and they're multiple, so usually more than 3 is kind of the magic number. So on biopsy of this lesion, what we see is this kind of proliferation, a lobulated proliferation of cells. And when we look close up for the cells, they have kind of like glands or some liquid inside, and basically those are sebaceous glands or facial oil glands. So this is sebaceous adenoma, which is suspicious of which syndrome? It's too bad that I'm not in person with you. That would have been more fun and more interactive. So that will be suspicious of Muir-Torre syndrome, and you probably know it more as Lynch syndrome. So when you think about the cancer predisposition in this syndrome, it's not only skin. Skin, of course, can be affected, but skin is by far not the most common, probably one of the least common issues in these patients. So some of the cancers above or all of the above is the correct answer. And as you probably guessed, it's all of the above. So this is another autosomal dominant syndrome, which is considered to be an allelic variant of Lynch, and it's caused by heterozygous germline mutation in the mismatch repair proteins. So to call it Muir-Torre syndrome, in addition to the diagnostic criteria of Lynch, these patients usually have to have at least one sebaceous neoplasm or a typical characteristic cutaneous tumor that we see in Muir-Torre syndrome, which is often sebaceous carcinoma or sebaceous adenomas or epitheliomas. But sometimes we see those tumors, which are called keratocontomas, and they are quite common, but they will be special in this condition. They will have this oil gland differentiation. If there are no sebaceous tumor, well, then it usually follows the diagnostic criteria of Lynch syndrome. So the role of dermatologists, particularly in this condition, is to suspect the diagnosis of Muir-Torre syndrome, refer to genetics, or at the MUHC we also have the Onco-Genodermatology clinic to confirm the diagnosis, consult appropriate specialties like GI, by example, for cancer screening and or treatment. And because this patient could be increased risk of skin cancer, we will typically do total body skin examination for early detection of skin cancer and treatment. So this to show you that some of the facial papules that kind of look yellowish are actually okay. So those are sebaceous hyperplasias. Those are harmless and they're not part of any syndrome. And you probably will see it in 1 patient out of 5 in your clinic. So the ones that are more kind of warty looking or kind of red, and there is a personal or family history of cancer, especially GI tract, those are the ones that you're more suspicious about it. So the extracutaneous neoplasm are actually relatively common in this condition. They can involve the gastrointestinal system, genitourinary, breast, hematological, and head and neck. So those patients are usually managed by multiple physicians, and we can help to arrange the screening if they don't have a primary treating physician. But otherwise, often patients have multiple doctors, they follow them. Okay, so you saw this is the differential of multiple facial papules. So it's a bit overwhelming, but we actually crossed all the important things on this page. So the multiple basal cell carcinomas, genetic syndrome is extremely rare. And as we discussed, basically it will be patients who develop BCC at young age, or they may have some additional features like palmoplantar pits, or the cyst in their along the jawbones, or some other dysmorphic features, by example. And we reviewed the Muir-Torre syndrome, which is also known as Lynch. And the other syndromes that you see here, they're so rare that I actually have seen only one case, so we can skip that. Okay, so this is another page, which actually as well amplifies the fact that when you don't know what basically there's multiple facial papules and they're not acne, they're not rosacea, they've been there. There's possibly some cancer history in the family, you're not sure. There's some additional syndromes that it can represent, and I'll show you some images of those. So this is called in. So we already alluded to this condition multiple times. So these patients this is actually not even that rare. We see about 20 to 30 patients a year with P10 hamartoma syndrome. So they can present with multiple facial papules that arise in sun-exposed area, typically around the nose and the cheeks, and around the mouth as well. So they kind of typically look a bit warty, like small warts in this area, but in adults, and they're not budging, they're not responding to treatment, they've been around for a few years. And when we start looking further, we see papillomas of the gingiva, and as well as inner mucosal lips. We can see papillomas on the tongue, and often by the time the patient is 50, there's already potentially a diagnosis of cancer or potentially a family history. So they can have some polyps along the GI tract, and they can develop cancer as well. So there's some additional pictures that illustrate the same findings. And again, you see the palmoplantar pits to which I've alluded earlier. So the common cancers that these patients may have are breast cancer, thyroid cancer, endometrial cancer, and they can also have gastrointestinal hamartomas, as in the images shown earlier. And cutaneous features are actually seen in almost every single patient, over 97%. And they could help potentially for the diagnosis in context of clinical suspicion because they're part of the major criterion. So they can potentially facilitate genetic testing. The other important consideration for this patient is that there is an increased risk of melanoma, anywhere from 2 to 5 fold. So we typically will encourage having at least once a year derm appointment for these patients for life. So I showed you this picture earlier. I think it was in the brother of this patient. So they're kind of this shiny, very small papule. You almost wonder what I'm looking at, but if you look carefully, you'll see that especially the nasal alar rim, you see this kind of shiny papules, and those are fibrofolliculomas, so they rise from the hair follicle. So by themselves, the tumors are harmless, they're nothing to worry about, but they are very, very highly specific for a syndrome called Burkhard-Dubé, which you may see in your practice. So I know there are respirologists on the line. So many of these patients in their 30s will present with respiratory, like lung cysts, and they can have spontaneous pneumothorax. And it's a relatively common presentation seen in more than 80% of cases. And they can also present with a lifetime risk about 15 to 20% of renal cell carcinoma. So very often the first diagnosis is made potentially through a dermatologist because they will complain of these lesions on the face. And this is my experience so far, is that all the patients that I've personally seen, they were referred to me by a family practitioner or somebody else for cosmetic complaint of multiple papules. And through the diagnosis, we end up doing screening for renal cell carcinoma. Another case of multiple papules, so you would say this is not papules, these are huge tumors. And you're right, this is Brooks-Pigler, but that was the last part of the major diagnostic tree. Those are also benign tumors, but they have a small risk of transforming into skin cancer. And as you can imagine, having that on us could be quite debilitating from perspective where it can actually affect the hearing. If it's around the eye, it can affect the eyesight, and it can be disfiguring. So one thing that we sometimes do in the clinic, we make sure if there's any clinical trials, the patient could be eligible. We'll try to make sure they will have the information about it. And if there are new techniques to remove them, we'll try to incorporate that in the clinic. So by example, this is a very simple technique where we just do a small incision and literally squeeze it out like a pimple, and it comes out. And so this is the results from this patient that you just saw the previous slide, healing up nicely, not perfectly, but at least having some local control of the lesions. And last but not least, a condition that is kind of dear to our heart because we see a founder effect in Quebec. So this was one of our first patients, one of my first patients. I think Dr. Fuchs saw many more over his career. So this was a 31-year-old Caucasian male who presented with multiple tender papules on the chest and back that appeared progressively over 10 years. A funny anecdote, he actually was not my patient. He presented to my community clinic because his wife was my patient and she was undergoing acne treatment with Accutane. And she brought him in, which is very common in our offices. They're like, can you just see quickly my husband? He has these lesions. And very often they're mistaken for scars, like keloid scars or acne scars. And for 10 years, he was just reassured that there's a scars and there's nothing to do. But of course, because we see quite a bit of these lesions, I was immediately concerned about something called leiomyomas and a genetic syndrome. And indeed, his sister had similar papules, and she was also not diagnosed at the time. And those are the pictures of his sister. So what you see here, you see skin color to erythematous. Sometimes you can darker, like brown color, depending on the natural skin phenotype of the patient, papules. When you touch them, they feel very different from nevi or from moles, which is soft. To palpation, those feel hard. They feel subcutaneous, like deep down. And when you touch them, they could actually be tender to palpation. So when we biopsy those lesions, they will show muscle proliferation, the spindle type cellular proliferations. And from a close-up, you see they're forming benign fascicles of muscle, which is consistent with pilar arising from the erector pili muscle, leiomyoma, or benign tumor of the muscle in the skin. So patients are growing muscles in their skin. When we see here with immunohistochemistry, we can actually look for the enzyme, and in this case, the enzyme is missing. So normally, what do we do for management of this case patients? If there's Onco-Genodermatology clinic, you can refer to us, otherwise refer to genetics. But most importantly is what can actually kill the patient will be renal cell carcinoma. So renal MRI is important, and referral to urology. So RHID syndrome, or hereditary leiomyoma renal cell carcinoma syndrome, is an autosomal dominant condition where the mutation happens in fumarate hydratase gene, which is important for mitochondrial respiration. The patients typically will have cutaneous leiomyomas, which is usually the first presenting sign. So examining the skin can be very helpful to ensure proper screening and early screening for renal cell carcinoma, which is very dangerous. So the estimated incidence says that it's a very, very rare condition, but this is not the experience we have so far. And many of the next slides are actually from our master's student and dermatology resident, Dr. Lydia Ushen, who I thank for providing the slides. So this is a focus of her master's. So basically, even though it sounds to be a rare syndrome, there seemed to be a founder mutation that basically that was brought to Quebec from France. And typically, regardless of the mutation status, there is a triad of presentation, which is the skin lesion that you've seen, but also uterine leiomyomas, also known as fibromas of the uterus, and renal cell carcinoma. So the cutaneous leiomyomas are present in, as per the literature, in about 70% of patients, not in our case. I will show you data from our own clinic. It's much more common than that. And uterine leiomyomas are also very, very common. And what's specific about it is that they will be bigger and earlier than what is expected. And the reported in literature mean age of hysterectomy was 34 years old. And that's similar what we see in our own data. Renal cell cancer, it's not that common, but it's 10 to 15%, which is much more common than general population. It arises early when patients are 30 to 40 years old, and it's very deadly with a 5-year survival of about 30%. So this is the specific founder mutation that is identified in French Canadian patients is called the C1293 deletion. And we feel, and there are some studies are ongoing, led by Dr. Folks and Lydia, really to try to estimate the incidence in Quebec, but it's definitely much higher than 1 in 200,000. So what do we have from our clinic so far? In 1 year, so literally like 10 clinics, we have 71 patients with this syndrome that are coming from 22 families. So when we look at their characteristic, almost all of them are French Canadian. And the mean age at diagnosis is in their 40s. So that means that there is a big delay before there is a diagnosis actually made. And more than 50% have this founder mutation that is specific to French Canadian population. Almost everyone has cutaneous leiomyomas, varying in number, that can be anywhere in the body except the palms and soles, where usually you don't have the erector pili muscle. Most of the time, they don't bother the patients, but in some patients, they can be painful and disfiguring. And most of patients, 71% of females had uterine leiomyomas, and half of them already underwent hysterectomy by the time we saw them. So when we look at the predictive value of cutaneous lesion in a skin exam, the positive predictive value is 91% overall in our cohort. But when we look at age 25 and above, it's reaching almost 100%. So it seems to be a very useful diagnostic bedside tool. However, the immunohistochemistry looking for the FH staining does not show similar results. This is some more examples of showing the lesions to you. And we also found that because it's a muscle, when you scratch it, the muscle can contract and the lesion become more visible to the naked eye, become plump. We call it the pseudodaria sign. Has never been described with Reed syndrome so far, so it's something that we're about to submit for publication. So the importance of management is primarily to confirm the diagnosis and screen for renal cell carcinoma, which is papillary type 2 and can be deadly. The surveillance recommended is usually magnetic resonance imaging. And female patients with symptomatic uterine leiomyomas should be referred to gynecology for follow-up. So principles of screening, the goal is really to start to screen early, to detect cancer early for a better outcome, and surgical excision, ideally, prior for cancer spreading. So this is the Canadian Urologist Association guidelines. So as you can see here, it's a little bit small, I apologize for that, but typically for papillary type 2 renal cell carcinoma secondary to this syndrome, the MRI screening is recommended to start at age of 8. So we typically really start doing it annually in patients who are 18 and above, but very often we will refer to Dr. Tanguay even before for potentially baseline screening, and then between 12 and 18, it can be as per physician judgment because of the problems with doing MRIs in children. So finally, the take-home messages, that was a lot of data that I presented, but we're proud to have this Onco-Genodermatology clinic, and we hope that it can bring value to you and your patients. So skin stigmata may point out to the diagnosis of familial tumor syndrome, and maybe the first clinical sign to suspect a diagnosis of inherited syndrome. And syndromes where risk of skin cancer is increased, such as familial melanoma, may also benefit from regular dermatology follow-up. There is no curative treatment for many of the cancer syndromes that we presented to you so far, but the screening and the skin-directed modality can improve the survival and the quality of life of our patients.
Apologies. Thank you so much. Congratulations. Thank you for this comprehensive lecture, and congratulations on setting up that clinic for the MUHC. Clearly, there's lots of colleagues for you to work with across a lot of different specialties. I'd like to invite people to answer questions in the chat because we have run out of time, so we have to close the official presentation. Enter the questions. Thank you so much for the presentation. Congratulations on the work you're doing, and keep up all that great work. Thank you.